what we'd like to do today is to share with you some of the work that we're doing on valvular heart disease. And valvular heart disease has been an interest for many, many years since I was a fellow here. And we've done contributions in so many different ways for aortic valve, mitral valve, etc. But the talk today is mostly about the mitral valve. And it is germane because if you go recently, these are two guidelines that came out simultaneously. I was privileged to chair the first one and for the country. And this is from the ACC AHA guidelines, highlighting the importance of valve disease in general. And this is a field that is evolving tremendously. Evolving tremendously because the therapeutics also, not necessarily the prevention, but mostly the therapeutics portion has evolved to catheter-based techniques. Now, although that has evolved, we still have a lot of issues regarding how do you quantitate valve, particularly valve regurgitation, mitral valve regurgitation. What are the things that conceivably we could learn more, either to prevention or to prognostication or to outcomes with everything that is coming on board from imaging technologies. And imaging has evolved so much over the past 10 years that you could see its impact one way or another. Now, one thing that we did, looks like this is going very fast here. So we're going to focus on the mitral valve, but there are a few things that are going on. One, yes, mitral regurgitation is, if you take a look at the aortic valve, yes, number one, but mitral valve, particularly mitral regurgitation, is among the most common disorders. Comorbidities, outcome, it affects almost pretty much quite a bit of the cardiovascular spectrum. And these are our current areas of research. One is germane to the new guideline that came out, which highlights, one, that you need to understand the pathophysiology. Two, that we have an issue in quantitation of valve regurgitation, particularly the mitral valve. Mitral valve is the most difficult. If you tell me in valvular heart disease, what is the most difficult one, it is mitral regurgitation. So we're going to try to address this issue for the next, I would say, probably 2 years or 3 years. Get more insights into mitral valve structures and properties and why, because that's important in prognostication and maybe understanding pathophysiology. And three is, the effort from Dr. Little and his team, and quite a few of them are here, is 3D printing of mitral valves and structures and so many other things. So that's what pertains to the mitral valve. I just want to share this with you because it's going to be an amazing data bank. And Clara is here and she's collecting this. And this is you don't have to read anything here. Basically, this is an effort because we have magnetic resonance, we have echocardiography, probably to the highest level, that we initiated something over the past few months, almost a year now, to do simultaneous imaging with echocardiography, with everything, all the tools that we have, and MRI. One of the issues that we're over the past 5 years or so is that many of these studies are not simultaneous, hemodynamics are different, mitral regurgitation is different, so I said, well, let's take that out and then try to do them as simultaneously as possible to answer many things. Ultimately, I'd like to develop maybe an app that will help you and help the physicians because heterogeneity and variability in mitral, come and sit here, and if we can get some more chairs, whoever is manning, there are some chairs here. So the variability in our quantitation and our evaluation is so tremendous, even within this room. If I give you a couple of cases, you'll see. Just imagine once you're out of here, it becomes a major issue. So this is an incredible database that so far we have 160 cases. Not all of them are valve, but I think, about 50 plus. The majority in blue are valve cases, so that's what we're going to target within the next few years, try to understand. And I know Shamsi Pasha and Dr. EL-TALLAWI are working on this. So let's focus on the mitral valve and understand some of its issues, what we're trying to do, and Carlos will also talk about his work that he's been doing over the past year. So I like this slide. This is borrowed from Dr. Little. And it says it's more than leaflets. And indeed, it's much more than leaflets. It is a whole apparatus that is amazing, actually, if you think about, if you're the creator, if you believe in one of them, of how can you put this whole structure for you to have a competent valve so that flow in systole goes into another direction. It has all these components. The annulus, you think it's rigid. I'll show you that it's not. The chords are certainly very important. Primary, tertiary, papillary muscle, ventricular function geometry. Once you have distortion of the ventricle, you know, the valve doesn't close as well. This is secondary regurgitation. So many other things. So coupled with that we've wrestled with for 50 plus 100 years, at least that we know from a medical point of view, is that imaging now has really come to the fore with a power enough to give us great time resolution, and I would think still decent spatial resolution to try to understand what really goes on and hopefully probe further into what this. So this is a nice TE from the atrial view, from the ventricular view that you could take a look at. And you can tell that the valve is not this beautiful, nice linear structure. It has lumpy, bumpy areas. It has scallops. It has so many things in it. And the variability among them is quite a bit. So if you're going to develop something to understand it, model it, it cannot be this theoretical issue. It's going to be something patient-specific, and that's the beauty of some of the work that we're doing. So yes, primary mitral regurgitation. This is the nomenclature now. It used to be degenerative. Yes, you could use them interchangeably. But primary mitral regurgitation is where you have, like this one, severe prolapse or even a flail versus a ventricle that is depressed, and you have, you know, more central-like regurgitation secondary. And it's important to keep those in mind because whenever you're interpreting and understanding, there are many things that go into play of these regurgitations. So let's delve into the mitral valve. This annulus structure that you see certainly is not planar. You know, it's a saddle shape, just like you see. So you could quantitate its height and its intercommissural distance and so many things, but you could tell it's a 3D structure that can be quite difficult to understand. Not only that, to understand it from a geometric point of view, but also from a functional point of view. Because from a functional point of view, if I draw the annulus, which is, you know, not circular actually, but it changes quite a bit during systole and diastole. You may not think about it every time, but that's how the heart is doing. And it's interesting because these changes, and you know, these are older modeling things that you could see from the mitral valve, and you could see them down in the second one, that every time the heart contracts, and you could see how steepened this saddle becomes during every contraction. So yes, it shrinks, it steepens, quite a bit of deformation occurs, and you know, now question is, how crucial is that? To tell you the truth, actually, we know some about it. We don't know everything, but we know that if you have deformation to this shape of the annulus, it becomes much more flat. Stress on the valve becomes much higher. So many things, I mean, and obviously it becomes larger and larger and larger. You may not have as much coaptation, so mitral regurgitation occurs. So yes, it's important, and you could say, what does it function? Well, it improves the coaptation of the valve. It reduces stress. The steeper it is. And if you think as a surgeon or an innovator, I mean, if you look, you go and Google and said, you know, annular structures of the mitral valve, each surgeon had its own way of doing the mitral valve. It looks like at times a dog bone. It looks oval. It looks circular. It looks oval. So many ways, so many different ways. But most of the others early on were rigid, and now we're trying to keep the annulus function still the same, right? And that's where some of the different surgical techniques occur, and also some of these flexible rings that you put in to try to bring down the size of the annulus are more flexible, so you hope that with your surgical technique you keep the dynamicity of the annulus itself. And this is some of the early work that Steve Little, when he was a little more junior, right? Did you remember that, Steve? Is you take a look at myxomatous mitral valve, functional mitral regurgitation. These are bad, bad hearts basically, and normal. And this is the size, mean area. Just look at, it's almost double or even more in mitral valve disease, mitral valve prolapse, degenerative mitral disease, of how big the annulus is. It's huge. Now you think only about, well, the valve is prolapsing. Well, it is a syndrome actually. It's quite a few other things go occur. You hear about disjunction, right, of where the insertion of the mitral valve is in relation to the muscle. There is a little space between the annulus and you hear about associated disorders, aortic valve disorder, aorta disorders, many other things. So don't think about the valve per se only as just, well, its motion is bowing back into the atrium. It has chordal issues, it has structural issues, and so many other things that go into play. And actually, this is one earlier study we did with Dr. Lowry and Sagit Ben-Zakri. Sagit, you'll see her name because she was here for about 3 years. And I mean, she was quite productive in rudimentary techniques at that time. And so it took a lot of time for us to do. So you see not large numbers of patients, but at least concepts that we're trying to put together. And these are resectional versus non-resectional repair of the mitral valve. So resectional meaning the either modified or Carpentier approach where you have quadrangular resection. So you take a part of that annulus out, mitral valve out, then you suture it so you get it closer, cinchers, and usually what happens is the posterior leaflet of the mitral valve gets frozen, does not function as well, as opposed to the non-resectional technique, popularized by Dr. Lowry and others. So, I mean, that's what Dr. Lowry does most of the time, is preservation. Basically, the valve is not touched. You put in an annulus with a continuous ring, and then you put in artificial chordae, so the valve is not touched per se. So you can think if the valve is rather large, and you bring in the annulus, so you're going to have some folding of that valve on itself. And, this is a resectional approach. That you could see that the posterior leaflet of the mitral valve is really not functioning as well, not moving as well, and this is the non-resectional one. It opens and closes almost like, and you could see the total ring there of the valve. The difference is, and we had to because we didn't do that, we had to collaborate with the University of Chicago regarding this, and because they still did the modified Carpentier technique. And you could see in red is after surgery. If you tinker and cut and do something to the mitral valve annulus and valve, the annulus doesn't move as much anymore during the cardiac cycle versus what we've done here is preserve what was there still motion of the mitral valve annulus, which may be important. We don't know how important it is. We know the observation is different. So you can think about, this annulus, how you quantitate it, how you evaluate it, and Dr. Azencott, who's head of mathematics at University of Houston, is right here. He looks Einsteinian, all right? and that has to do something with mathematics and physics and modulation. But we really have appreciated quite a bit of his insight, and he's French in origin, so we can practice a little French from time to time. And but that collaboration has been here for, I don't know, Robert, long time. We don't have to date, but probably 8 years or something like this, 8 to 10 years. So, he introduced us to a few things about the annulus and curvature in 3D. How do you plot a certain geometry in 3D, basically? And it has names of torsion and curvature. And I don't want to bore you with the details, but now actually you could describe a shape of an object in 3D, and this is your normal, and these are individual patients with normal organic mitral regurgitation. You could see how large and how flattened the annulus is versus after mitral repair. I think the valve annulus is coming back together, and then if you take a look at what really happened with these curvature numbers or torsion, they come back to either close to normal, or actually they can get corrected depending on what your surgical technique is about. Okay? So few things about the annulus to finish up with is regarding the annulus is it is a complex structure. It's not as simple as you think. It is dynamic. The disease of the mitral valve or the ventricle can affect its motion, its size, and so many other things. The measurements are, classically, if you take a look at any of these vendors that give you this, they'll give you some perimeter, area, and some intercommissural diameter, AP diameter, a 3D structure projected into 2D. But there are ways with the torsion and curvature that you could do those in 3D shape. And we know that surgical techniques, depending what kind of surgical technique you're using, you can affect what goes about. So that's one area of the mitral valve, because I think we take this as also instructional, because we try to understand more and more about the mitral valve. How about the leaflets? We haven't talked about the leaflets, and I know all of our eyes usually are on the leaflets themselves. And the leaflets are amazing because you can take a look at the structure. We have an expert, actually, Jane Grande Allen. I know some of her postdocs are here, some of her students. I don't know if they came or made it. Here you go. And she is really a renowned expert on the mitral valve characteristics, tissue. She grows mitral valves, and she's been here for more than 10 years now, almost 15 years. At Rice, and I know Dr. Little and us, we collaborate with her on different things. And but if you take a look at the structure of these valves, they're, normal valves have a certain structure, but you take a look at the Barlow disease or fibroelastic disease, their properties are very different. And I just mentioned to you that it's not only affecting the valve per se, but you have to think even beyond the valve. Because it is a disease of the connective tissue of that particular valve. And you could think of that its properties are going to be quite different, similar to the different properties of the chordae. And if we understand more of the properties of the mitral valve per se, does that help us in prognostication and understanding disease and understanding why calcifications occur on a particular valve? Does it help us in prognostication even after you play around with the valve and try to repair it, be it percutaneously or surgically? So one thing that we did, besides measuring its size and its thickness and everything else, is started to think with Robert as to, what else, with now imaging technique, what else can we do? If we look at deformation conceivably of the valve, every time systole occurs from diastole to systole, or you can pick 2 time points, be it mid-systole and end, that the valve starts deforming depending on pressure in the ventricle, systolic pressure. And therefore, you can understand its properties. Are these properties important in prognostication? We don't know. But at least we wanted to see whether, number one, can we put our heads together, mostly the mathematician's head, to model a patient-specific valve and see what really happens with imaging technology to strain. Now, strain from ventricular side is that it's deformation of whatever structure you're looking at. So we use strain clinically for myocardial strain, right? If the heart compresses, the number is negative. If it is stretches, it is positive. It's percent change. Bottom line is percent change, okay, of a certain length. But you look at strain also. Strain is, to be critical, is a 3D deformation, is what really happened to this structure if I compress it or stretch it, right? In 2D, an echo for the ventricle, you look at one vector most of the time. It's longitudinal strain. You forget what happened radially, you forget what happened circumferentially, right? Here, the valve is thin. It's not incredibly thick. It'll be very hard to look at the other dimensions. So you're going to look at basically the planar structure of what really happened to these 2 tiny, areas that are very small from mid-systole, let's say, to end systole. And this is where our, mathematical geniuses have tried to put together. So, stress and strain of the mitral may relate to intrinsic properties. We don't know, but we suspected when we did that. Can we determine strain from 3D images? That was not known, and I think we know from pilot studies now that we can. Now, these were the initial questions. What is the strain distribution of the mitral valve? I mean, is it different depending where you are in the mitral valve? And we know in systole, for example, there's a large vector that goes in the alveolar flow tract of flow. And then you have some Venturi forces, and the question is what really happens to the anterior leaflet compared to the, Peng, you can come here. What happened to the posterior leaflet? I mean, vortices are very different and pressures are very different in the valve. What is the strain distribution in health and disease? Is it different? And these myxomatous valves or fibroelastic deficiency are different. The surgical repair of valves, I mean, to tell you the truth, that was the first impetus 10 years ago. Dr. Lowry doing his preservative technique. Why is his maybe better than others, right? What happens to strain? What happens to stress and modeling? And that was the first one that we wanted to. Now, you get into the research just like anything else, start asking different questions, and you build something different. And I think that's the beauty of research, is it takes you in different pathways at times that you don't think about when you start thinking about a study. Okay? So that's what we did at first, and these were published within the past 5 years, you know, whatever it is. Take the pictures, send them to Dr. Azencott and his team. They had to kind of track what happens to the mitral valve from a portion of the cycle to the second cycle and look at almost 1,000 points, right, Robert, or something like this, or what really happened to these 1,000 points. And then you had to delineate where the mitral valve is, so it was very tedious from a work point of view. Sagit had to, you know, give them about 50, whatever it is, 100 points to play around, and then they do the modeling, and then you bisect the valve into its anterior and posterior leaflet, and look at the commissures, look at the zone, and then you can take a look at different zones of this valve. And take a look at the annular portion, at the coaptation portion, posterior, anterior, you could divide it, whatever it is, provided the basics were done, meaning I can track this valve from a time in systole to another time in systole and look at what really happened in between. So this is an example here of a mitral valve prolapse that you could see. You could see where the hole is for mitral valve prolapse. You could see bulging. And these are the more difficult ones to model. That's Dr. Azencott, I mean, because it's quite deformed as opposed to a nice normal valve. So you could take a look at that. And then you could see the changes, what really happened to this mitral valve. And then ultimately you could have a heat map, or, you know, a map of strain of where in a normal valve that you could see on the left, much less of the brighter, you know, yellow, orange, which is high strain, compared to a valve that has significant mitral regurgitation, and on top of that has disease. You could see much more strain in that valve compared to the other one. Okay, and then what we did here is take a look at organic mitral valve versus normal, right? And you can notice one thing is that posteriorly in red, posterior strain appears to be in those 10 patients. I mean, okay, can we, you know, but that took a month with an S at the end to come up with these, is that the strain posteriorly is much higher than anteriorly, right? And interestingly enough, we hypothesized that maybe because the posterior strain is so much higher, and that's why you have, every time you see calcification of the annulus, it is posteriorly located. Well, that could be, you know, just imagine every beat, right? You know, the valve stretches. Every beat. You have a few billions of those, right, in your lifetime. And then where is the stress? And most of the strain is towards the annulus at the outside. These are the black dots, and towards the commissures, and these are the highest ones of the strain. It doesn't mean it's not existing there, but it is there. And this is the latest work, actually. This will be coming out in JACC imaging in a few months, accepted, and I just saw the galleys. So this is pre and post. This is what we wanted to do. And at times, research, takes time, particularly these kind of prospective things where you really want to develop something. I know at a fellow, your time frame is 3 to 4 years, and then you have to jump into something else. But at times, you're part of an equation, right? You're part of a process that takes time. So this is where we started with. We started to find out whether strain changes after you do something to the mitral valve, and indeed it did. If you take a look at here post-operatively, the strain has come down, actually even at times lower than what it was before, because the annulus gets much smaller. The exposure of the mitral valve is much less than even a normal situation. And I didn't think about that it would be actually lower strain than a normal valve. So this is the normal situation, anterior, posterior, and global. Post-op came down significantly, and at times it's even almost similar to a normal, at times even lower than normal. Can I take these to the bank? I just don't know. These are 10 patients were done before and after. These are 10 normals. So all of our studies. And why 10? Because it's a nice round number. It's less than 20, more than 5. Okay. No statistical modeling to come up with the number 10, but more importantly, it took forever to do those 10 patients. Yes.
Normals were matched to the one that had surgeries?
Age, and you can match for a few things, and that's about it. I mean, remember, all these are TEEs, right? So these are TEEs from normals, and so I mean that's what. This is where we are at this stage from data point of view, okay? From data point of view. The question is, you can't hang everything on n equal 10, right? Number two, there are many other things that you'd really like to know, right, in patients. So we said, what can we do to enhance this process? One thing we thought about is maybe to get in touch with one of these companies that do tracking, and TomTech was one, so we were able to get the software to track the mitral valve, and so Sagit or Carlos doesn't have to sit down and give you every little point of the mitral valve, what happened to it. So that took a big chunk. What can we do from a processing to try to improve it overall? And all this is really getting much better now, to be able to almost do it within 10 minutes as opposed to days. So and we got Carlos EL-TALLAWI from Lebanon, who is interested in this work, and basically put an RB together to have a large data bank of patients and do as many patients in almost every scenario, because we have a distinctive tool. We don't know what comes out of this tool. We know we can study a property of this valve, right? And I think at some point in time, it may be important. It may not be important at all, and it would be an exercise and whatever it is in mentation. But unless you test and unless you find out, you won't know, okay? And this is part of research. If everything was nicely shown to you and said, oh, it's going to be positive, it's going to be negative, it's going to be whatever it is, well, that's not research into some unknown. So there's always risk in research, and we don't know what the risk is, but we know at least from the initial signal, right, from the initial signal that there is something there. Does it mean, from a clinical point of view, I cannot tell you what it means from a clinical point of view, but I thought that with Carlos's effort, and he put an RB together to have a very large database, he's going to share with you how large the database is, because he's put efforts almost every day, not only to do that. Peng is here. He's a student with Dr. Azenkot, and he's been refining all the mathematical modeling and everything else. So it's really a great team effort to try to push this to a second level. So Carlos, come and share with them what you have done so far.
Can I ask a quick question?
Yes, yeah, go ahead.
So the complexity of the apparatus, do you think that might result in transcatheter mitral repair maybe being confined to the high-risk patients, not being as successful as TAVR was? Because it might not ever replicate.
Are we talking about total replacement of the valve?
Yeah, like TMVR.
I mean, it has so many different issues, right? And remember, part of the issue there is you're not replacing the valve, you're adding a valve to a valve structure. You're not excising the valve. Now, we got away with in the aortic position because initially you get concerned what happens to the aortic valve with calcifications, everything. Out here, you have a bigger tissue, bigger area. What happens in the LV outflow tract, depending on design and so many other things. I don't think it will be part of the equation. Ultimately, yes, if you have a lot of calcification and so many other things, that's a hindrance by itself, or it adds complications to it. At times, it could be beneficial because you can anchor a valve to a calcified area as opposed to a very soft tissue. I'm not sure that the valve structure or whatever we're dealing with here would do. I know it would alter, it would certainly alter the mitral annular dynamics because you're putting a fixed structure in there. But if you got to a point to put a total new valve, I think it's a moot point. You understand what I mean? You're not going to be able to preserve the dynamicity because you're not repairing the valve. You're completely replacing it. Okay, Carlos.
Thank you, Dr. Zoghbi, for the introduction. So moving just a few slides at the end for an update for where we are right now and what we are doing and how we update the work. Basically, the general aims of the study now is to collect as large as possible of a database of mitral valve 3D images acquired on TE, of course, from a variety of patients, all sorts of patients, for whatever indication of the TE, as long as they have a human tissue and they have decent images, basically. And from these 3D images, we're doing patient-specific mitral valve models using a new software that is automated. And then using this software, we're trying to, using the other software that Dr. Azencott and his team developed, we're trying to calculate strain. And from this, we're going to compare basically different groups of mitral valve, normal versus abnormal, within the abnormal, primary versus secondary MR, calcified, everything, basically try to define the groups and compare them together. I'm going to show at the end a general idea about the groups. And determine whether strain is associated with or predicts, for example, the development or the deterioration of mitral valve disease. Also, an area of interest that Dr. Zoghbi talked about is the effect of mitral valve repair and the types of mitral valve repair, the resectional versus non-resectional. Would it change strain? Would this change in strain predict the outcome, the recurrence of mitral regurgitation in these patients? So, as I said, the inclusion criteria is basically any patient undergoing ATE who has a mitral valve, not bioprosthetic or mechanical. Informed consent should be, of course, signed, and we need good images. Otherwise, the exclusion would be a prosthetic mitral valve, poor images, or any significant mitral valve endocarditis because it would affect the tracking of the software because of its effect on the leaflets. So this is sort of technical, basically. You can see this in the lab up on Founder 9. This is the acquisition protocol. It's not probably very relevant to this talk right now, but this is basically how we acquire from the TE, how we get to the 3D image at the end. And this 3D image is what we use and input into the software to make the model. So basically, after bugging every fellow and every physician probably in this room for almost 5 months, which are like more than 100 working days, we got 242 patients, almost average 2.3 per day. 63 were excluded for different reasons. And right now we ended up with 179 patients. 2/3 of these are male and 1/3 are female. As for the distribution of the indications and the mitral regurgitation severity, as you can expect, most of the indications are related to atrial fibrillation, whether it's cardioversion or ablation. The second most common are MR and endocarditis, and the others would be, as expected, Watchman assessment, stroke, some congenital defects, and other valvular disease assessment. As for the cohort of, as for the whole cohort, actually, we have also, as expected, most of the patients would have no MR, around 60%. 21% have mild MR, 13% have moderate MR, and we have 6% or 10 patients have severe MR. We defined a normal valve as a valve which has no MR. The patient would be in sinus rhythm, no other valvular heart disease, normal ejection fraction, and no calcium in the leaflets and the annulus. And from this, we have a core of 25 patients, which we are going to use basically to define what is a normal strain for the anterior and the posterior leaflet and different areas of the mitral valve, and from there go to compare against the other mitral valve pathologies. Within this normal cohort, it's roughly divided equally between males and females. As for the mitral regurgitation types and severity partitions, almost double, we have secondary MR almost double as primary MR, probably because most of the indications are AF. A lot of them have heart failure, low EF, causing secondary mitral regurgitation. So we have a total of 51 secondary MR and 23 primary, and you can see how mild, moderate, severe, and mild, moderate, severe for secondary and primary, how the numbers go down. In the cohort of the primary MR, which are 23 patients, we have 5 patients who have flail, 8 patients who have prolapse, 3 patients with rheumatic, and 7 patients who have calcific etiologies. Next, I'm gonna show 5 cases, basically, which will describe how we go from the initial 2D image until we get to the strain values. So as you can see, this is the 2D image, the 3D image on TEE. The bottom video here shows how the software automatically tracks the leaflets, and it's showing only mid to end systole. That's why you don't see the leaflets opening, and this is what we are looking at, from mid systole to end systole only. And then using another software, we go from this to this, a visual representation of the strain on the leaflet surface with the map showing the numbers going from 0 up to 0.3 or 30% strain. And you see at the bottom the quantiles of the strain distribution on the anterior and posterior leaflets. Basically, the curves below show, in a way, reflect the homogeneity of the strain distribution on the leaflets. So to understand this curve below, basically it's, for example, if we take the 60% quantile, you can say that on the anterior leaflet, which is the non-interrupted line, 60% of the leaflet surface has a strain of, let's say, 0.07 or below. The same goes for the posterior, of course. So it basically reflects the heterogeneity. We will see in the next cases how this goes into play. This is a case of severe primary MR or Barlow. Again, you can appreciate on the 2D how the leaflet is prolapsing, the same on the 3D. I rotated the model here to the side so you can appreciate better how the leaflet deformation is happening. And this is actually what we are trying to move or to translate into numbers. And this is what we get here. Again, the heat map showing the locations where we have high strain distribution. And at the bottom, you see how the strain quantiles are distributed on the anterior and posterior leaflet. And if you remember before, it was like around 0.1. Here you go, the numbers go up, like, which means there are certain areas on the leaflets that go up to 0.15 to 0.2 or 20% strain or deformation, which is
20% stretch. It's not small. These are the local.
Next is a case of moderate secondary MR. Again, this is a case of low ejection fraction, dilated ventricle leading to a dilated annulus. You see how the leaflets are coapting and how they are flat. A central mitral regurgitation. Again, you see how the distribution of the strain is also high. That's what I was mentioning before, how you see like when you go up to the 80% quantile and up, how the strain values go up, which means that 80% or below of these leaflets have almost, I don't want to say normal strain, but low strain values. But you reach an area that is like 20% maybe of the leaflet surface that has a higher strain value, which reflects this area here, which is at the medial commissure. Next, I'm going to show a case of mitral valve repair, non-resectional, one of Dr. Lowry's cases. I didn't show the modeling, but you can see how the same software that does the modeling also does some calculation of the annular dimensions and leaflet dimensions. So I showed here pre and post-op how the annular circumference drops significantly from 14.4 centimeters to 8.1 centimeters. At the same time, we show also the same thing, the strain map and the strain quantiles. And I chose here, for example, at the 75% quantile, how you see a significant drop in the strain between the pre and post-op. And you can see it actually on the heat map. You can appreciate it by the color.
This is interesting to me.
Because this is a secondary MR. I mean, it's
This is
very
second-
interesting because
yes.
we have not tested secondary. I mean, this is the first case of IC of secondary MR. And remember what I talked about is if the annulus is flattened, is much larger. These valves are like this as opposed to like this, right? So strain I mean, is it also important because secondary MR repair is not as good as in primary MR.
Again, last case I'm going to show here is a case with mitral annular calcification and the posterior leaflet, which you can appreciate here on the 2D image. Also, after calculating the strain distribution, this is basically a very maybe premature observation so far because we haven't run all the calculations. But I noticed in this case specifically that if you go to the strain location on that leaflet, which I don't know if it shows here, but basically this circle, yellow circle here corresponds to this area here from the MPR here image. So basically what I'm trying to say is that this area here had, which is the calcified area, had a lower strain compared to the other areas. It would be expected, I would say, based on the calcification of that area. Maybe the leaflet is more rigid, it doesn't move as much. But again, this is very preliminary right now.
Carlos. Well, those are all very nice cases, very clearly presented. The question I'm wondering about is the impact of the presence of regurgitation on the strain maps for a given tissue property. So if you have, the mechanobiology of those leaflets or whatever they are, and the strain or the deformation you can nicely capture. But that strain, the deformation, that depends on the properties, but also the pressure on the properties, which is the stress.
Mhm.
When you bring in the ventricular pressure. And if you have a pop-off you develop MR, for example. So let's say your strain map in P3 may look a certain way, then you develop a P1 flail. So now you've got MR, which is lowering the ventricular pressure, yet the strain, I guess the question is, how does that affect the strain regionally with big changes in pressure like that? Do we know that yet?
We don't know yet, but actually I was thinking about it a couple of days ago, about the effect of MR, because you would think that MR would, as you said, diffuse the pressure in a way on the leaflets.
I mean, MR would be the theoretical problem with the presence or absence of MR. The other way to maybe test it is just acute changes in LV systolic pressure. Like phenylephrine infusion or hand grip exercise, things that have been shown to increase afterload, increase ventricular pressure for a fixed tissue property, and then try to get at how does the LV pressure impact the strain map. Because really your strain is kind of a surrogate for stress. Stress is what we care about, because stress we think equates to longevity, not so much strain.
Which we cannot measure right now as easily. But yeah, I mean, part of our, which I'm going to show in the next slides, part of the comparisons is to compare the effect of blood pressure and the effect of afterload increasing valvular heart disease, for example, AS, to try to see the effect also.
Steve, this is
So-
a very important question. Actually, before they accepted that paper, the reviewers asked, what's the effect of regurgitation on strain? Because as you suggested, conceivably, it will reduce it.
Yeah.
Our response to them was, yes, it could reduce it, but even with the reduction, strain is higher than normal.
Yeah.
You see what I mean? I mean, if it was similar, I couldn't take it off that, but if it is in that direction, and conceivably it could be in that direction, then strain would be even worse
Yeah.
if there was no regurgitation. And hopefully in this, I mean, Carlos is going to show it, hopefully in this cohort, we should be able to address it. And Dr. Herrera is right here, because if we want to test one thing about the effect of blood pressure, it will be in the operating room. After a surgery or during surgery, pressure is changing. You're infusing an inotrope and a vasodilator and all this. So each patient is their own control. Yes, volumes change and other things, but also pressure changes. I think it'll be great for us to take a look at that and see. Because we may not find a relation of blood pressure in a normal population to strain. Why? Because that delta BP is rather small, right? And you're not going to be able to play around with them, right? And in an outpatient TE, you're not going to infuse inotropes, right? Shouldn't do that. So even for science, I wouldn't do that. But I think you have a physiologic situation in the OR for us to be able to do that.
Plus, I don't know how, like comparing mitral regurgitation to a normal mitral valve. I mean, are you comparing mitral regurgitation to the normal, or the etiology behind the mitral regurgitation to the normal? So if it's
fast forwarding is a potential clinical application. Ultimately, if the tool might be applied to post-surgical repair, is the strain map sufficient to predict good durability? If that's the
Yeah.
question. Well, you have to kind of index the strain to the presence or absence of MR. Because, for example, imagine a lesser surgeon, if some person actually existed, and they produced an MR repair that was maybe not as mechanically robust, but also leaked. Then, in fact, the high strain can be masked by the presence of MR.
yeah.
So the two might go against. So it'd be hard to figure out which is actually the better repair if you don't normalize for the presence of MR.
But a leak is always bad.
A leak is bad. And then you have the intraoperative negotiations. How bad is it? What's mild really look like in the OR?
So at the end, I'm going to show basically all the combinations of the possible comparisons between the different patients groups. So we're going to try to compare at least the normal strain values, try to find out actually the normal strain values globally and regionally. What are the determinants of the strain pertaining to the mitral valve itself, the thickening, if we have prolapse, calcifications, or pertaining to the ventricle itself and the blood pressure. Is strain in mitral valve prolapse abnormal without mitral valve prolapse without regurgitation? Is it abnormal? And does it localize to a certain location where the prolapse is maybe? And would the outcome be different if we have prolapse without regurgitation with high or with normal strain? Again, does the severity of MR affect the strain values as we just discussed? Is strain different between a primary and secondary MR? And what is the effect of the mitral valve repair on the strain? And does the improvement in strain after repair confer better durability? And also, since we have different surgeons who do different mitral valve repair techniques, we have the option to compare these techniques actually, in general, the resectional versus the non-resectional. So these are the general, basically, outline of the comparisons.
You can put that last slide too.
Okay.
I mean, this is the team, actually. The team are from two organizations. I think Dr. Azenkot and his team have been really phenomenal in helping to put together this developed this strain map and modeling for being patient-specific. If you look at the literature, really there isn't anything like it at this stage, and I think it is a possibility for us to take mitral valve structure to a different level. I know hopefully we'll tap on the expertise of our bioengineers next door, and this is the clinical team. Carlos has done a phenomenal job. Jessen, I don't know if Jessen is here, but he's concentrating on the OR. Mohammed is going to be quite involved, and these are, you know, the other people involved. Dr. Herrera, she's taken the lead in the OR. Lowry, innovative from his surgical techniques, and it's good to have other surgeons who do things differently, because we wanted an internal control, and now we have actually surgeons who do things differently. So we don't have to go outside. All right, well, thank you for coming.
Thank you.
Any questions?
You know what Dr. Little was saying, you know, it's every beat. You have to think it's like, you know, you're measuring it, but every beat may be different. You know, so like, you know, if the blood pressure is lower, then you might not have so much MR. It's all so dynamic.
Indeed.
That, you know, you're measuring strain, but that's strain of one beat, right?
Yeah.
Actually, we're measuring strains on 2 beats.
Okay.
Yeah.
And
But,
it's different.
but I mean, you know, it's
And
2
it's
beats.
So the question
Yeah.
is, how do we use 2 beats?
Yeah, exactly.
So to you, it's only 2 beats.
Yeah.
Or it was.
But so basically, it could be bad for those 2 beats, but, you know, it's a cumulative thing. Strain is a cumulative thing, and that's what you're talking about is the, you know,
True.
what you want is was no MR, ideally.
Any questions? You got everything in there.
Yeah.
Well, Robert, any thoughts from your end?
Well, I mean, one of my motivations is that Charpentier and his school in France were so proud of their techniques that they wouldn't accept any kind of argument against the fact that they are doing it and this is why it's so good. And so I was very happy to meet a team here who might have doubts and think that maybe people like Charles Lowry and others were doing a good job. So since I'm French, I felt that for once a Frenchman should try to help bring contradiction. By the way, the Charpentier school is doing well. They are not perturbed. So that's just not a question, it's just a vague comment.
Well, that's great. All right, and thank you all.
Thank you.